Coming up next on Insights, Hawaii's neighbor island doctor shortage. Aloha and welcome to Insights on PBS Hawaii. I'm Malia Maddock. The doctor shortage statewide is getting worse. Hawaii needs at least 900 more physicians to keep pace with our medical needs, and the shortage is expected to increase to 1,500 over the next 5 years. The state's doctor shortage is most obvious on the neighbor islands, where many people go without the care they need or go elsewhere for treatment. 5-year-old Hayden Betts of Waikoloa, Hawaii Island, is just one example of a patient who must go off-island to receive appropriate treatment. She was born with one leg shorter than the other. She and her family are regular travelers to Shriners Hospitals for Children in Honolulu. Tonight, we'll address the factors behind this doctor shortage and look for solutions to the problem. Please share with us your questions and comments by calling 973-1000 if you're on Oahu, or 800-238-4847 if you're on a neighbor island. You can also watch Insight stream live at pbshawaii.org. Just click on the title of tonight's show or find us on Twitter at PBS Hawaii. Now to our guest for tonight's show. Dr. Linda Rasmussen has been an orthopedic surgeon with the Windward Orthopedic Group for 21 years. She is a past president of the Hawaii Medical Association and is currently the organization's legislative chair. Dr. Rasmussen founded the advocacy group Hawaii's Save Our Doctors. The group is a nonprofit coalition of physicians and others who have been adversely affected by the increasing shortage of doctors in Hawaii. Dr. Josh Green is an emergency room physician on the Big Island, which is very much affected by the shortage of medical doctors. He is also a state senator, and he has repeatedly introduced legislation to address the state's doctor shortage. He was part of a major collaboration to establish the state's first neighbor island residency training program at the Hilo Medical Center. Earl Betts of Waikoloa is directly impacted by the shortage of physicians in Hawaii. He is the father of 5-year-old Hayden, whom you just saw in our introduction, and whose medical condition requires ongoing specialized care in Honolulu at Shriners Hospitals for Children. Mr. Betts is on the board of directors of the West Hawaii Community Health Center. Selina Hayashi is a first-year medical student at the University of Hawaii's John A. Burns School of Medicine. Born and raised on Maui, Ms. Hayashi plans to return to Maui to practice medicine after she graduates from medical school. Thank you, everyone, for coming tonight. Welcome. Senator Green, let's start with you. Can you tell us, are there patients in our state who are suffering or even dying because of not having enough doctors available?
Certainly. There's no question about it at all. When I work in the hospital in the rural parts of the Big Island, we see people with all kinds of disease, whether it's advanced diabetes or cancers that have advanced much further than they should have because they were diagnosed late. Sometimes individuals can't be cured then. They can't get to good oncologists, whether they're somewhere in the neighbor islands or here in Honolulu, and that can cost them their lives. I've witnessed people in traumas, which is big car accidents or injuries out on the ocean, that have passed away when, had the accident occurred nearer to a trauma team in these past years, they might have made it. Now, we've made great strides. We created a trauma system. We've done what we can to integrate our healthcare system, but there's no question some of the challenges are great in the Big Island and all the neighbor islands.
Dr. Rasmussen, do you think that this doctor shortage can be explained simply, or is it much more complex why this is happening?
No, it's very, very complex. Many people get out of residency and say, oh, I want to live in Hawaii. And they come and they realize the price to send their kids to school, the price of housing, and the low reimbursement. And they're like, I can't make it here. So that's one factor. And not everyone, that moves here, really fits in here and stays here. And then you have just trying to run a business in Hawaii. It's very, very difficult. And practicing is difficult. And for the physicians on the neighbor islands, they don't have an infectious disease specialist, let's say, to refer their complex case to. So you're stuck taking care of things that you may not be real comfortable caring for. So that puts an additional pressure on physicians that makes some of them uneasy, and they could maybe be on the mainland where they have a full complement of specialists available.
And it's less of a battle.
Yes.
Ms. Hayashi, we were all speaking a little before the show, and student debt came up. What doctors have to first overcome to even start to make the money for the cost of living in Hawaii. Do you think that's a big factor for medical students and those approaching the medical field?
Absolutely. But at the same time, I think that what's so admirable and inspiring about my classmates and other students that I've met is we've recognized how expensive education is, but understand the worth, the value of it, and we still took out those loans and are still in medical school. And the cost, it's difficult for us to fathom now, but I think it's worth it. We definitely regard it as our calling, and so I think, and I have faith that it will work out, and just putting our patients first and caring for patients, I think, is what we are really passionate about.
And so even if going back to Maui might mean you make less money than you might have on Oahu or elsewhere, it's worth it?
That, yes, and also I think it's been a greater impetus for me to apply for a lot of scholarships, and I've worked throughout undergraduate, and I think that's a big factor also.
Well, that's one of the absolute mechanisms that we can get doctors to go work in rural areas. I came to Hawaii with the National Health Corps, which was a 4-year commitment, and my first job as a doc was in Ka'u, so very rural on the Big Island. I'd come from Pittsburgh, so I didn't have the first clue about Hawaii, and I was embraced immediately because people were so appreciative of having a young doctor in the community, and that paid back my loans. But I can tell you there was no other circumstance that a guy coming from good medical school and residency program out in the East would have landed in Ka'u. Because had I had, well, I did have $145,000 in loans back, that was in year 2000. Had I had that debt and I'd been kind of recruited to come to Big Island, given the circumstances, I couldn't have made it work. I was single, I didn't have much other responsibility, but because I was able to have that scholarship and that loan repayment program, I could do it. And I was immediately assigned 8,000 patients to care for, the most wonderful people ever in Ka'u and South Kona areas. But most docs only take care of 2,000 patients, and I was a first-year doc.
So you were saying there is something Hawaii could do to sort of prevent that type of situation. What could we do? Well,
we should and must have a comprehensive loan repayment program for everyone in primary care, and from my perspective, also the specialties, provided that they're committed, the specialists, and they are, because they're wonderful people, committed to taking care of Medicare and Medicaid and so on. That's our model. If we put about $5 million a year into a program, this is, I guess, me as a senator talking, we can get about $5 million of additional federal match. That would enable us to pay back almost everybody's loans, and we would have a surplus of physicians. But it takes political will, and it takes a commitment. We could maybe get the private sector to contribute also. But in a way, that's a big ask because there's a large disconnect. People think, well, why do you have to put that money up for docs? You don't have to. But if you don't do something dramatic like that, you won't, without a lot of luck, fill in the nooks and crannies of our state.
Mr. Betts, I see you nodding, and you're someone who's living in those sort of nooks and crannies right now. What is your life like at the moment, needing to come to Oahu for medical treatment for your daughter?
At this moment, it's not that bad. She's in between her surgeries. There'll be a couple more surgeries before she turns 18. The hardest part was getting my entire family over here. We had a 3-year-old daughter going through this really elaborate type of surgery with the Taylor?
Elizarov.
The Elizarov
Yes.
frame. And it's very, very intense. There's a lot of hands-on when it comes to the adjustments of this frame.
And we're looking at pictures of your daughters right now. Could you tell our viewers a little bit more about what you're needing to do for her?
Right now, not too much.
In terms of the medical aspect.
The medical aspect, we do have to come over here for checkups every now and then. She needs to come over often to have a new brace fitted. They have to make sure through a series of x-rays and different medical procedures that everything is growing according to the plan. Right now she's doing well, she's growing very well, so we don't have to go back and forth as much. But as we get closer to that second surgery, I know that we'll be back a lot more frequently.
And this is care that there is no choice other than coming to Oahu to get it.
There's no choice.
And his case, you know, Earl with this beautiful Hayden, is very illustrative of one of the big challenges which transcends the questions of low reimbursements or medical malpractice issues or just a general shortage, because his beautiful daughter needed some really advanced care, which doesn't happen often. There's only a relatively small handful of children that would need that very complicated surgery with excellent specialists like Linda and her team and other specialists in the community in Oahu. But we simply wouldn't have enough cases, say on, of course, Lanai or Maui or Big Island, to be able to support a whole team of that level of specialty. Therefore, we will always, for some health problems, need to come where there's a dense population where you can have a practice. So that's one of the things we'll have to understand as an island state, that for certain things we'll have to come to Oahu. However, having said that, like what Linda referenced earlier, we all know that we need to have infectious disease doctors. We've got this big infectious disease problem on Big Island. We have dengue fever, for goodness sakes. We have...
And are there infectious disease specialists in place on the Big Island?
They only fly in very periodically. So this is how crazy it is. I'm out there in the neighbor island taking care of people. I see a serious infection. I'm a little lucky. My wife's cousin, Heath, went to Mayo Clinic, got his training. I call him up at all hours of the night. I send him a picture of a serious infection. He helps me through it. If I didn't have that relationship, I might not have an infectious disease consult. If it's bad enough, I have to send him to Linda or Dr. Pian or some other infectious disease doctor here in Honolulu. And that can hold true for a lot of the subspecialties and a lot of the challenges, which is why we're so encouraged when we find a terrific young woman like Selena, who's not only going to get trained, but she's going back to the neighbor islands.
Linda, you were mentioning earlier that the demand for your type of specialty on Maui is amazing. Can you tell us about that?
Right, so I do mainly joint replacements, new hips and new knees, and I do a new procedure called Makoplasty, which is done robotically, and I'm the only one in Hawaii that does it. And so it's kind of started with that, and then I found all these people that should have had a new knee 10 years ago, and they've been given injections because there's not the resources there for that type of surgery.
So had they been on Oahu, your suspicion is they would have already had this problem addressed.
That's right. So it's time off work. But not just that, it's the mental anguish, not being able to sleep at night, not being able to get around, not losing your independence. That's a big deal for people, even, middle-aged and especially the elderly. I mean, you really want to maintain your independence, so it's difficult. So now they got to fly over to Oahu, and there's more than one visit, and it's a lot to, bring the family and to fly over and to have the care and go back. So I think it takes a toll, and that's the important thing, is that not only the physical, but the emotional toll that it takes on those people.
Oh, you're getting support through Shriners. What would you be out of pocket on this in terms of the travel expenses and what Linda is referring to? Were you not getting the help?
The travel expenses alone, we'd probably be out about $20,000 right now. For the surgery and all of the pieces, moving parts of that, we'd probably around $1.6 million, roughly.
Wow.
That's a lot of money, and I can tell you I don't have it.
Yeah. Well, I mean, other than the support you're getting through Shriners, are there ways that we can change this for people on the neighbor islands where they won't be facing down that type of travel bill? What is the answer?
Well, the answer really should be that people get comprehensive coverage in every way. So we have to accept the fact that there's going to be need for people to move around, and so that should be taken off the table. I mean, I fly as a legislator back and forth all the time, and I see a lot of people, and their friends and family and constituents, they're flying over for healthcare services just for the day or for an overnight, and they come get a quick surgery and they go home. we have to factor that into the healthcare system and our healthcare costs. And that's what insurance is about. So a good insurance program is great. I want to definitely give special props to Shriners because they have a model, of course, where they don't basically charge you anything because they are so compassionate for children like Earl's daughter and the people that I've seen, and they have an autism clinic. They do all these things. But we have to subsidize the whole system, which we do. As you're aware, all of the rural hospitals, the neighbor island hospitals, are essentially public hospitals, HHSC hospitals. About 20% of their budget ends up being subsidized by the taxpayers because of these problems we've described. So we already have a subsidy and a challenge to get people care, and we still have to help people travel. So it's just one of our, I think, our responsibilities and commitments here in Hawaii to support the healthcare system.
Selena, do you hear these kind of gaps being discussed among friends and family on Maui?
Absolutely, and I think that's a big reason why myself and some of my classmates are interested in medicine, because I think it's affected a lot of our families. I know we've all had to either come to Oahu or sadly had to wait on Maui as a loved one came to Oahu to get a surgery or procedure. And especially in medical school, we have these interest groups that discuss these issues, and something that I became more acutely aware of this problem was there are so many more layers to this issue. I mean, if only one parent can fly over with the child, and the child, of course, doesn't want to be alone at all. And so one time I got to volunteer and just give the parent 45 minutes of just a break so I could be with the child, and the parent could, exit this room and see the outside and get a Starbucks or whatever they needed. So I think it is an issue that we're all very familiar with, but coming up with an innovative and realistic solution is something that I think takes involvement from the community as well. And we need to get people to really buy in and understand that it's an issue that we don't have to just say, oh, it's a problem, we'll get used to it, but to understand that everyone deserves equal access to health care and the ability to have their families with them to cope with healthcare. And because health and illness and wellness affects your whole person. It's not just, you're not just a mass of cells that get sick.
And as Selena touched on, the idea of having your injured or sick or a baby who needs this kind of surgery done, and one parent going, for one, we discussed it, my wife and I, Nicole. Nicole is a labor and delivery nurse up at North Hawaii Hospital. So she's got some medical background. Years ago, I was in the mortuary services, so I have some medical background as well. And the idea of having only one of us there, to us, felt overwhelming.
Yeah.
We didn't think that one of us would be enough for what my daughter needed, as far as emotional support. And then my wife would need support. I know I did, so. But
for families facing down that huge travel bill, it could be a decision that would have to be forced.
It was jumping off of a cliff because, you got a 2-income family with now no income. For 34 days we were here.
And then it's so culturally embedded in Hawaii to have, very few families have only one child. If you have multiple children, it's so difficult to uproot everyone. I think it's such a, it really hurts my heart to think of these families that have to go through that.
Let's go to some questions. This one is from Kauai, from Martin Wessler. A frequent solution put forth in forums on doctor shortages has been that nurse practitioners should be used to fill in more to support the care shortage, to free up doctors to use their skills where needed. Would you agree?
Yeah, there's no question that is a part of the solution. The system is changing. So several years ago, actually I sponsored that bill and it passed, that allowed nurse practitioners to function as primary care providers. The goal is to have them work in partnership in a collegial relationship with the physician who is going to tend to have more training, but nurse practitioners are extraordinary healthcare providers as well. They will have certain limitations. They won't be able to do a surgery like Linda can do, or maybe certain procedures that I can do in the emergency room, but they can do incredible work on preventive services and many acute services, and we're already seeing that change. We're about, like you said, somewhere between 700 and 900 doctors short already. We have about, say, like 3,500 full-time equivalent doctors. We need so many more. but it takes so long to train a physician, and physicians can be comparatively expensive to find and have them work in the health center that Earl is, on the board of, or in one of the hospitals I work in. So you might have 2 or 3 mid-level providers, meaning nurse practitioners or PAs, that can support a practice. So what you'll see in the future is you'll see physicians perhaps working in partnership or overseeing a group of 5, 6, 10 nurse practitioners providing care to a lot of people, but the doctors themselves will be spread out. And that's the kind of model that the insurers are promoting. I wouldn't be shocked at all if that becomes the predominant model. But I'm going to be candid, there are definitely times when people want to see a physician who's had a certain extra set of skills or training. And there's no shortcuts in healthcare. So sometimes someone will see a nurse practitioner and it will be extraordinary, but sometimes they'll still want to have follow-up.
Dr. Rasmussen, do you like the idea of a greater presence for nurse practitioners filling some of those roles?
Well, it's interesting. My daughter is just graduating from college, and she's making this decision going to be a PA or being an MD. And the additional training is huge. So I have 4 years after medical school, then I got 6 years of residency. So you're talking 10 years after college. And I'll tell you, there's a lot of additional knowledge that comes with that, a lot of additional confidence to deal with different complex issues. And I think my daughter is kind of leaning that way after working with me. Because,
towards nurse practitioner?
No, towards going to medical school. Just because there's, all that additional training definitely makes a big difference with your knowledge base and being able to handle different things. So I think there's definitely a place for the PAs and the nurse practitioners, but we can't expect them to really come in and take over. You still need the physicians.
So if I'm understanding correctly, this is not something that either of you feel needs to be handled on a sort of legislative level in terms of nurse practitioners. It's just more whether the model is naturally going to move that way.
Right. Well, 2 points that are important. We did handle it already legislatively. Now we expanded to the extent that was practical and safe what a nurse practitioner or a physician assistant can do. However, the reality is it's an economy situation. You have a lot of patients with a lot of needs, and you have a very small number of physicians, and so we can only do so much. One thing that I would say is historically America has done some extraordinary things in healthcare, and we've done some crummy things in healthcare. We have not done a good job making sure the uninsured had access. We haven't done a good job with prevention. We've done a great job with severe critical illness and surgeries and advanced treatment. So a lot of what you will see will be the mid-level providers, the nurse practitioners and PAs, hopefully augment all those things that we didn't do a great job on, that I would even say we neglected for years. But you will still definitely need the physicians to do the advanced oncology or the orthopedics or the OBGYN work.
Has the Affordable Care Act or Obamacare made it easier for doctors? I'd like to...
No. When you add more bureaucracy, what happens is it takes more time to get the approvals for different things. This electronic medical records has just been like scream, pull your hair out. It adds a lot of layers, a lot of additional headaches and additional time that you're spending. So now I have a scribe. So every time I see a patient, there's a scribe there recording everything, because otherwise I'm in the office till 9, 10 o'clock at night trying to put in all the information that needs to be in the chart. So physicians actually are retiring early, which is not what we want. The suicide rate for physicians is double that of the regular population. And you got all this bureaucratic things that are thrown on top, and the reimbursement's gone down. So you're trying to pay for the people to help you to support all the increased paperwork that you have to do with less money.
Your opinion in terms of?
I would agree with a lot of what Linda has said. Definitely the bureaucracy's worse, the payment structure is more challenging. The good piece of Obamacare was we got more people covered, and we had to do that.
That's good.
Yeah. The bad pieces are, though, that it took so much oxygen out of the room for healthcare changes and reform that we were unable to get to some of the core issues, which is what you have us talking about tonight. We could have taken that energy and had a much, much smaller appropriation to pay for every possible physician, nurse practitioner, PA, and nurse to get training. We could have doubled the physician and healthcare provider workforce for a fraction of the amount of money and energy that went into the Affordable Care Act, and we would have had a real, palpable, in the trenches solution for the patients that need it. That is the bill that should have been written. What did get written was a product of the BS that goes on in Washington and the special interests and the lobbyists and the big pharma and the big hospital games, all that stuff. But that's not about people. People want to have a nice young doctor, a surgeon, a guy who's running a healthcare center, maybe an ER doc. They don't care about those EMRs and bureaucracy. And so if I had to say do it all over again, I would say fix it.
And of course, there are people who, as you've mentioned, have benefited greatly from it. Is there a perspective in terms of young up-and-coming doctors-to-be on that issue?
I think that we understand that there's a lot more work to be done. I think it's important for us to be excited about change and understand that there's so much more. I think that we can support things like expanding residency programs because we've expanded enrollment in medical school. However, what's the point of educating doctors if we can't then complete our training? So I think it's very important for us to support expanding residencies here and just kind of shifting the attitudes in terms of patients so the community can participate as well, especially when their doctor comes in and asks, oh, is it all right for a student to be in here with you or do some of the basic parts of your physical? I think sometimes it's met with resistance, but what they need to understand also is, we're getting evaluated on our performance, so we are going to make sure we do a very good job. And we studied all night to make sure we had the order of the entire physical memorized.
Get the best service ever, right?
Yeah, the people in Hawaii are very wonderful. I mean, that's why I'm here. I love the people. And they really are very accepting when I have a student or anything that involves training someone that may help take care of them and me one day.
Mm-hmm.
So how do we get a homegrown model in place where we, like you, here you are, you going to school here, you're from here, and you want to serve here. How do we get that to happen? Short of throw more money at it, and then if that's the only answer, where do we get the money?
Yeah, the money is the key. I mean, that's the bottleneck. Earl's exactly right. We really need to pretty much double our capacity for training. And Dean Hedges, let me just give him props. I mean, he does a fantastic job at JABSOM. The people who are committed to training our residents, so fantastic. But he's limited to 60 to 65 spots a year. He would like to expand 10 or 20%, takes extra money. The residency positions need to be expanded very significantly. If we did that, we could get ahead of the shortage because we could double down on the docs we produce here. And the statistic is basically 85% of those who train here, whether it's in med school or residency, stay, which is the best in the country for many reasons. Obviously, family, proximity, the distance from the mainland. But we can only train so many. And we're actually going to start losing ground. The last 3 years, we've been straight up flat. And we're going to get the new numbers here in a couple weeks, and we're worried. Dr. Kelly Withy, who does this work, and we should give her credit, she's concerned that the numbers could drift downward a little bit. Then probably it will light a fire under people. I know that there are private interests out there, philanthropists and so on, that seem to want to step up. But it will be difficult to get state appropriations to do it because I think it's hard to penetrate the mindset of paying for doctors to be trained.
And tonight we're discussing the shortage of medical doctors in Hawaii and its impact on the people of the neighbor islands. We'd like to hear from you, so please call, email, or tweet your questions and comments. Call 973-1000 or 800-238-4847 if you're calling from a neighbor island. Let's go to another question. This is from Dr. Hannah Preston-Pita. There is so much research to support the initiative for allowing psychologists with the proper training to prescribe psychotropic medications. Would something like that be a solution to this? In other words, more people available to prescribe the medicine that people might be looking for? Any thoughts?
It's one of our missing pieces. We have a serious behavioral health issue here in the state, and that I think that's maybe our lowest. Not sure. I don't do the math there. I'm pretty sure, though, that there are fewer psychiatric or psychological.
That's a need. Mm-hmm.
What's a need? And I've been all over this issue over the years. It's highly debatable, okay? I won't demagogue the issue. I will say this. When we did a study about 7 years ago and looked at the amount of extra training that it would take for psychologists to get up to speed to the place where they were adequately trained like a psychiatrist, at the time, and this may have changed in the last 5 to 7 years, we only predicted 5.8 psychologists, or just under 6 full-time psychologists, would go through the whole program, get that training. So it would make an almost unnoticeable dent. Now things are changing. We have the pharmacy school. They're excited about doing this. But once again, this is the debate because Linda made the point very clearly earlier. A physician will go through, well, in her case, 10 years, but a psychiatrist will do it at least 7 to 8 years. And it's a lot less training. People just have to know what they're getting. I mean, I know a lot of brilliant psychologists, they're terrific people, but they will have less training than a psychiatrist. And that is one of the great challenges. If we do it, I would say this, that you really better build in a full tilt collegial relationship where a psychologist can rely on a psychiatrist for backup. Because I'll tell you this, I'm a trained MD. I've worked for many years as an MD. When I see a patient with acute psychosis and needs major drugs, every single time I still call a psychiatrist to make sure I'm getting the meds right. And I've had one heck of a lot of training, and I would never start someone on those medications without that relationship and that conversation. So you can imagine the reservations that some docs have about this change.
I totally agree. And 50% of people with arthritis are depressed. So I see depression and pick it up and go, okay, I got to get something, but I would never touch those medications. I mean, they're very dangerous. And it's difficult to get someone in to see a psychiatrist or even a psychologist. Sometimes they just need counseling, but the ones that need to see a psychiatrist, it's not easy to find someone, to get them into. We need more psychiatrists, we definitely do, but you gotta have people with training. Those are very dangerous. Those are the most dangerous medications I think we deal with.
Interesting. The card I just picked up was Tom from Eva Beach, our mental health provider, a psychiatrist, also in short supply. Is it particularly acute on certain neighbor islands or just across the board?
Across the board.
Across the board.
It's across the board.
Even on Oahu.
It's over 25% shortage in that discipline. And so there is a space for collegiality and the bill may pass, and then we will make sure that we do everything that we can to make sure it's safe. Because again, I'll say, psychologists are terrifically smart. The psychiatrists are terrifically smart. But they are going to have to work together. And also be mindful, if a large amount of time for some psychologists gets taken up, who's going to be there to do a lot of the talk therapy and a lot of the support therapy? So, like I said earlier, there's no shortcut. So we need to be training more psychologists and more psychiatrists and more family practice doctors. I mean, we have to do all of these things, and that's the only way we'll get to a solution.
What's the single hardest field to sort of fill those spaces? And if you had to identify one that was the most critical, what would you name?
The hardest, as far as the greatest shortage, well, in general, primary care. If I had to say one thing, because the need is so vast and everybody needs a primary care provider, that's the great equalizer, right? I mean, if you don't have a primary care doc, the system doesn't function well. People only go to the ER and see me. It's way too expensive. We don't have a good organized system. So start with primary care, and systems all across the world that are built on primary care tend to do better, because if the primary care docs are good, then they know when to reach out to the Linda Rasmussens of the world to get that knee replacement. When the infection is at its worst, those are the patients they get there. If you don't have that safety net and that really that expert base, there's chaos.
But that's one of the hardest to fill, because if I'm understanding correctly, is it not one of the least financially rewarding, if you will, of the different areas? So it's hard for someone graduating with debt, needing to and wanting to take care of a family in a very expensive state.
Well, there's an analytical answer to that as well, and that's absolutely correct. The American Academy of Family Physicians studied this very carefully, and what they found was if you can reach 70% of the median income for specialists in a region, it tips and people go into primary care. So doctors are more than willing, people are more than willing to be paid less and to carry larger debt as long as it's somewhat close. If you can't get close, then the medical students and the residents tip into the specialties, which is wonderful. We need the specialties too. We need pediatric endocrinologists. We need colorectal surgeons. We need all these things anyway. But we're so short on primary care for the day-to-day stuff that we have to put extra incentives. And that's why we're focusing our loan repayment programs, and Dean Hedges is focusing extra efforts to get primary care going.
All right, for Mr. Betts from Frank on the Big Island, what would you have done if Shriners hadn't stepped in?
That would have left us with a large decision, and we'd have to decide, is it worth going back to the mainland? Is it worth
Relocating so you could afford it.
Right. You know, how do we take on a debt that large? And there's nothing, most parents would do anything for their children. And as much as I love being here, if it meant the health of my daughter would be in jeopardy from being here, we would have been gone.
All right. From Trina and Kaneohe, would the panelists discuss telemed, and is it used widely in Hawaii? You want to take that one?
Yeah, we use telemedicine actually quite a bit at Shriners. I work at Shriners occasionally, and so we'll do some telemedicine for education from different Shriners from around the United States, and then we use that sometimes with our kids on Guam or Truk or Palau, and so it is used there. I think there is almost an art in medicine, and so for me, being able to actually make eye contact with that patient, be able to touch that knee, feel the crepitus, feel the ligamentous laxity, you lose that with telemedicine. And the patient needs to be able to trust you if they are someone that needs surgery, and it's very difficult to establish that. So there are some areas where, it's not the answer necessarily, but there are some areas where it's very helpful for. Someone can text me, I do, have a lot of patients from Maui, I'll get texts with pictures, oh, does this look infected? Or, and that's very, very helpful. But it sounds, I think, a little rosier than it actually is in reality for the reasons I described.
Well, in addition to the telemed angle for Shriners, they also do outreaches.
Right.
At the neighbor islands, in Guam,
Yep.
all over the Pacific. And my daughter has been seen on our island by the Shriners probably more than she's been seen over here.
Yeah.
For the follow-up, it works, but only 2% of Hawaii's providers are using telemed right now. I would expect that'll move somewhere to 5 to 10%, which will help. For all the reasons you brought up earlier, imagine Earl not having to get on the plane with his beautiful kid and have extra costs, $500 for the day, traveling, she's hurting, all that. It's perfect. But if you want to get a physical exam, I can't listen to your heart telemed, basically. So you've got to come in. But the systems are changing. The insurers are now going to be reimbursing for telemed. They're going to build it into the schedule so that it works in your practice as long as it works in your life. So, and this next generation, Selena's generation, they live with their iPhones and their iPads, and I think it's going to be common. There will be an app for med school, and I think it is part of the future. But once again, I'll say it for the third time, there's no shortcut. If you really want to get good care, I have to be able to feel his arm, feel his elbow, listen to her heart and lungs, and if I don't, I run the risk of blowing it.
Missing something.
Yeah.
Gets lost in the mix. Tom from Waikiki asks, is there a doctor shortage on neighbor islands simply because none of them want to live there? Selena, I'd like to send this question to you. You do want to live there. I'd like to add, what do you know that you're giving up by making the choice to live on Maui versus Oahu or a bigger city?
I think of it more of what I'm gaining. I think I'm gaining so much from going back to Maui. These are the people that I care about. They're the people. They're the reason why I want to be in medicine. They're the community that enabled me to be where I am today.
Is there anything you think you're giving up?
There is, I think, a certain attitude amongst some people who believe that the best medicine is practiced here on Oahu, here in Honolulu
Ambition would drive you towards the bigger city.
Right, and there's research, and if I want to be involved in certain capacities as a faculty member at the medical school, that would require me to be here. But I think that there's a large reason why there are fewer doctors on the neighbor islands, I believe, is because there are less of us that are in medical school, less of us in college, and I think a lot of that has to do with not having enough mentors or people in the community. I mean, none of my doctors growing up looked like me or were from my community, and I think that's a huge thing. I was very much so inspired by doctors here who, you know, are from this community or have poured out so much into this community and have been willing to mentor students and help us to realize that just because you're from a certain area or you didn't go to a certain school, that's not a barrier, that you can still be an incredible, intelligent, competent, compassionate physician. And I think that's something that we need to all understand.
Foster the change.
Absolutely.
Yes. Linda, from John and Kailua, why is reimbursement so low in Hawaii?
That's there's two reasons. One reason is with Medicare, we are not reimbursed for our cost of living, and we're basically reimbursed as you would be in Kansas rather than for our cost of living. So if I do a hip fracture, for example, in San Francisco, I'm paid $339 more, but yet they have a similar cost of living, and our congressmen and women have never done anything to change that because it's got to come from another state. Then you have really one insurer, and they just pay you whatever they want. We have no unions, we can't negotiate fees. HMSA said a couple years ago, well, we're paying you $200 less for each total knee you do. Well, I do a couple hundred total knees a year.
So
that's
significant.
A huge amount of money, and there's nothing I can do. So the public doesn't really realize, you know, what I used to get paid 20 years ago and what I get paid now is like less than half for the surgeries I do.
And that is stressful.
Right, and my rent has doubled, my malpractice insurance has doubled, all my expenses have doubled. So we're in a unique situation where our income is totally controlled by the government and the health insurance, but our expenses can, you know, continue to go up. There's no control over the expenses. So it's like telling Safeway, well, you have to sell your milk for $2 a gallon. We can't stay in business doing that, and that's why a lot of practices are going under. I know people that have used their savings just to continue to practice medicine and are not even making what a school teacher makes to practice medicine. And that, you know, but they're not going to say anything, but that's how bad the reimbursement is.
You'll see other people, so that will affect the model, right? So some physicians will retire, some will become hired physicians. You'll see more of that because then they won't have to deal with any of the overhead or the billing or those issues, but that changes the way they can practice. That makes them, as employees, they have to take the cues from the institutions, which are usually good cues, but it's a very different kind of medicine. But it's why you will see fewer and fewer, in all likelihood, independent physicians working solo with a, you know, shingle hung up on their door saying, you know, Doc Green, come in anytime. So the world will change some. People are experimenting with other payment models. There's all kind of interesting and creative ways that people are trying to make a living.
I would think it would have to swing back because people need doctors. So at a certain point, the more that they are crunched down, at some point it's got to swing the other direction, doesn't it?
Well, I have said that a bunch of times, but I don't.
You would think.
Yeah,
You're still waiting.
Yeah.
Wait for the spring.
But I'm not sure. I think there is a tendency when there's a serious need and people really do love their doctors to find a way to make the system work. And HMSA is working on a new model they're hoping to make work as a payment model. But
Could you, in brief, give us a synopsis?
HMSA is talking about a new model called they're calling it Payment Transformation, or Mahie 2020, and the jury's still out. It's about to get launched as a pilot. My organization, Hawaii IPA, is working on this. But basically, it would doctors get paid a lump sum on the 5th of every month based on how big their practice is and how sick the people are, be guaranteed that money, and then they should focus on all kinds of other things. So we don't know if it will work. We're hoping that it will bring down the complexity of their admin work and let them just focus as docs. That's what we want as physicians to do.
Right.
We want to just practice medicine, and so we want people to know that we're there for them, but all these other challenges still hang over us sometimes.
Linda, you were mentioning before the show that there is one bill died already in terms of forcing doctors to accept Medicare patients.
Yes.
So that's out, and you all feel that that was the right way to go on that?
Well, I think all doctors should see Medicare and Medicaid in a nice proportion to their practice.
But requiring it's hard.
Well, it's just not going to work because, for one thing, you would have immediately made Dr. Hedges give up his medical license or any number of training and a lot of mentors. So that probably is not the best approach. The best approach is to figure out fundamental solutions to these problems that you've mentioned, like improve reimbursement somewhat, improve ways to get doctors to go into practice through loan repayment, find ways to have great schools in the community so spouses are happy, and all those solutions are better than a mandate telling people exactly what you have to do. Because what will happen, if the mandates are too bad, people will fly over and work in California or Texas or New York. It would have backfired, so that was ill-advised.
But there is another bill that's still alive that, Linda, you feel would help doctors.
Yeah. Well, as of December 1st, HMSA requires approval by an outside mainland company to get an MRI or CAT scan or any diagnostic test, which once again requires extra time by our staff, by us, and then there's the delay in care, which can have significant impact on the patients and adversely affect their overall health. There's a bill that would put the liability, if any adverse thing happened with their health, that it would go on to the insurance companies, and that's HB 2740, and that has passed the House. So that's a positive thing, but you have these physicians already stressed, and then in the middle, it's like, oh, I need to get an MRI. I operated on a patient today that I didn't get an MRI on. I said, well, you know what? We're going to spend 3 weeks. You can't walk. Your knee's locked. You got a meniscus tear or something's catching it. Let's just operate. And she's like, okay. But normally I'd get an MRI on that person. So it's not a good thing.
All right, let's go to some more questions and comments from Mahealani Richardson, who frequently hosts this show. Hospitals like Shriners, Kaiser, and Queens are opening more neighbor satellite clinics. Is this helping?
Yeah, it's fundamental. That has to happen. Their commitments are wonderful. These are organizations that are quite philanthropic. Their mission at Queens, and Shriners, Kaiser, you can't beat it really. So a lot of times there's going to have to be, that's another way we're subsidizing the healthcare system, just like opening community health centers and being sponsored by the state and federal government. Some of these other clinics are going to be sponsored by these big facilities because they tend to have big revenue. A lot of the money goes to hospital care, goes to big pharmaceutical care, and so what you'll see is a cycle of corporate support going back into the system. It'd be better just to run the system smart, pay people the right thing, support these clinics appropriately, and not have to rely on that, but we have the system we have.
All right. Earl, I think this is something you mentioned before the show from Pam on Kauai. How many doctors are set to retire soon in Hawaii? Is that something that we had talked about earlier, or?
I don't think that was me.
Okay. Anyone want to take that question?
It is, I think when Kelly with the Allen looked at it last, it's like 25%. And a lot of them are just holding on, and because they enjoy practicing, they enjoy their patients, and they have no one to hand their practice off to. That's the big thing. And they finally get to a point where I can't do this anymore. And I think you add in the electronic medical record. I know a lot of physicians that just said, okay, that's it, I'm done. And then you add in, the having to get approval for every step you make. Physicians are like, okay, that's it.
And we have the highest proportion of older physicians in the country. That's, I think, the statistic that is daunting. So we better live a long time, and our docs better be ready to keep at it, because these young ones, they only come up every 4 to 7 years.
Right.
You were going to jump in on that. Is that something you're aware
I was
of?
just going to mention that as well. Yeah, absolutely. Which is exciting for us because we will have patients, but also, as you said, quite daunting.
Many patients, many parents. Now, on the financial side of this, since we're talking about doctors, means of making a living, by not having anyone to take over the practice or to sell the practice to, is that another financial blow?
Well, it's pretty hard to sell a practice because you're trying to sell it to someone that is $400,000 in debt.
So it's not going to happen.
Right, and I think a lot of the younger physicians want a 9 to 5, they want to work as a hospitalist, so they want to be hospital employed. So many of those people are going to Kaiser where you're not on call. I'm on 24/7. I work every single day. I don't have a day where I really take off unless I go to the mainland. And that's stressful on families and stressful on the person.
And you can't even sell a practice because the demand is so high that if a physician is properly licensed and properly trained,
they don't need
to buy the practice. They set up anywhere and they're going to be overpopulated immediately.
Right.
Yeah. I think we're starting to get into the final part of the show. I'm going to try to get through as many questions as I can from Bob in Waikiki. Has there ever been a program to reach out to Department of Defense doctors who are A, ending their first tour, or B, about to retire, and trying to recruit them to work here, Outer Island?
A specific program I'm not aware of, although we're in constant recruitment mode and the hospitals are always looking. So once we know someone's licensed, we try to hire them.
All right. From Paul in Kona, how much attention is given to homeopathic remedies, especially dengue fever? Is that a part of the conversation, sort of alternative medicine?
Well, naturopaths work in a primary care capacity a lot of the time. Those remedies don't help you if you've got an allopathic problem, like a big surgery need or a major problem with diabetes for the most part. But up to 30% of people like homeopathic remedies and naturopathic care, and I respect that. So we want to include everybody in the system because we're short.
And I think many of the physicians nowadays include that. I mean, I spend a lot of time with my patients. Turmeric's an excellent anti-inflammatory. These are things you can do.
It's being incorporated.
Stress release. Yes, here's books you can, self-help. Here's websites you can go to deal with your stress rather than taking meds. So there's a lot that I think
we learn about it a lot in school,
right.
too, which is very important because Hawaii has the highest rate in the country in terms of states that use these complementary medicines. And a lot of times I think there is this aspect of we want to make sure that we know what's going on with our patients, and so that we can understand what they're going through. And especially it's so important to recognize the differences in culture and how that affects how they view medicine.
This is more of a comment from Dr. Linda Anagawa. Recruiting and retaining qualified positions in our state, perhaps physicians in our state, involve so much more than training hundreds more students to become doctors. Until the problem of one payer's near monopoly here is rectified, training more physicians may actually make the problem worse. Do you agree with that?
Well, I think the monopoly is a big thing, and the reimbursement is a big issue, and trying to make ends meet is very difficult. I had a partner pass away at 49, and trying to replace him, it's taken us 2 years to replace him. And the only way we were able to is we were able to find someone local from here that was willing to come back.
Highly motivated.
And take, a third of what they could make on the mainland.
All right. From John in Honolulu, would doctors receive better compensation if they were serving under a universal health care system like the rest of the world? Thoughts?
I don't know if they've received better reimbursement. There might be some benefits. There might be less kind of crazy paperwork. It's possible. Some of the admin responsibilities and billing would be less. We may head that direction. If the system continues to trend towards very, very high cost and difficulty with providers, that could happen. That's a gigantic debate, which I think I've even been on the show a couple times to talk about. We could see modified single payer. Just depends. We're spending $3 trillion on healthcare already in our nation, and the Medicare population is growing enormously. That could tilt us and tip us over to a single payer model.
From Kevin on the Big Island, the drug companies should pay for more doctors. The more doctors, the more drugs prescribed. Linda, any thoughts on that?
Wow.
No.
That's a bad pairing.
Yeah, right. That doesn't pair at all. I use very few medications. I try to empower the patient to do their exercises and do things to take care of their health rather than relying on medication.
But I do agree that there is a disproportionate amount of this big money, this pot of money that we say goes into healthcare that's going towards big pharmaceuticals. I do think it is important to kind of assess where the funds are going, and I do agree that if we were able to kind of change how much the large amount of student loans that we come out with, that it'd be easier for us to go in and take this smaller pay in order to benefit the most people in our communities.
And she's so right, because only 10% of the healthcare dollar is spent on primary care in our nation, 10%, whereas about 25% is spent on medicine, some of which cost hundreds of thousands of dollars. By the year 2020, a full 1% of the U.S. population will spend more than $100,000 a year on their pharmaceuticals. I mean, that is out of kilter. There's some doctors and nurses that will, for their whole salary, get paid less than that. So the system does have to be fixed.
Well, with pharmaceuticals, it seems like the money's not in the cure, it's in the management of it.
A lot of it.
So you're just going to draw it out as long as you can.
I think we're in our final minute. I'd like to go around the table very quickly. If you could have one thing change, one tweak, what would it be, Linda, to help this problem?
I think it would be nice to have insurers that are going to adequately reimburse the physicians and the other healthcare providers, nurse practitioners, for the care that they actually provide.
Right. Earl?
Keep the homegrown model. Raise them here, grow them here, teach them here, and employ them here, but employ them a workable wage so that they can actually manage to live here and stay here and thrive here.
Josh?
I would say we should restore ourselves to a time where we totally trust the primary care providers, whether it's the primary care docs or the nurses and physician assistant associates. Trust in them to, whatever they have to do, take away the administrative burden so that they can use their extra time to take care of patients.
So make doctors' lives, the quality of doctors' lives less stressful.
Right.
All right. Selena?
I think what's very important is for us to all whether we're students or doctors and people in the community, patients, to take ownership of this issue and realize that it's not something that happens in a vacuum, but that it has a lot to do with advocacy and government and advocating for our patients, advocating for our doctors, and to realize, these bills that are on the table in terms of expanding residency, supporting our medical schools more, and also putting more funds into our education system and encouraging that child in your community, your cousin, whoever it may be, that they can be a physician and make a huge, incredible impact.
All right, that's a nice note to end on. Thank you all so much for joining us tonight. Join us next week as we examine a key juncture in the state legislative session known as crossover. That's when surviving House bills cross to the Senate for consideration and vice versa. Next time on Insights on PBS Hawaii, that will be it for us this evening. Thank you.